Now, this is a sponsored symposium. We have Dr. Umar Al-Hallaq, is a consultant interventional cardiologist and head of cardiovascular department, King's College Hospital in Dubai, United Arab Emirates. It's a great pleasure to have him with us to give us a talk on the PCSK9 inhibitor offering a new horizon of patients suffering from dyslipidemia and recent acute coronary syndrome. So Dr. Umar, welcome, and leave the floor for you to address your talk, please.
Thank you so much, Dr. Akbar, and thank you for the invitation. I was asked to talk about offering a new horizon in a patient with dyslipidemia and acute coronary syndrome. Where are we now? Of course, we are doing intervention all day long. It's very interesting. I just was going to, just a small comment, in between bracket before I start, about the cardiogenic shock. It's not really my talk. I think it's cardiogenic shock is not just pure hemodynamic ischemic problem. In my opinion, is 60% chemical intoxication of the heart and the body, and 40% probably hemodynamic ischemia, quote unquote. And the reason I have this kind of feeling is we do all the revascularization, we do all the support of hemodynamic, and patients still die. So there is still something missing. We don't know what it is. But in my opinion, it's something chemical going inside the heart and everywhere else. And the same example, we have it in septic shock and so on. You kill the bacteria, but the patient still die. But that's, I just want to add on it. I didn't have a chance to talk when I was there. But something kind of, I think there's something we have to look other than out of the box of interventional cardiology. Anyway, back to our talk. Where are we now? Well, we have, of course, more data to support lower LDL is better. And the lower we go, we decrease the chance of future cardiovascular events. As you can see here, between 2016 and 2019, there was some more aggressive goal to be achieved. For patients with high-risk patient, we were asking for less than 2.6, 50% reduction, or 2.6 or less. In 2019, 50% reduction and less than 1.8. And the very high-risk patient, we're looking for less than 1.4 and 50% reduction. And this target, of course, it's getting harder and harder to get in there. But the curve, as we're all familiar with it, the lower you get, the lower chance of cardiovascular event. For the patient who have second event wall or maximal medical therapy, the target now is 50% and less than 1 millimeter, less than 40 milligrams. What does the real world do? What does the data show? Well, unfortunately, it doesn't look good at all. And that's the reason we're still seeing a lot of blockages and a lot of intervention and keep interventionalists so busy. They have in this study, you're Aspire, I'm sure you are all you are familiar with it, with 7,000 patients, almost 8,000 patients. They have CABG, PCI, or acute coronary syndrome, and they did the follow-up on their lipid profile, and turned to be less than 30% of them attain the 1.8 old guidelines. And if you apply the new guideline, it's going to be, of course, much worse. So more than 70% of patients, they are not achieving what we are looking for. And that there is, I guess, one of the reasons why those patients keep coming and keep having problem. And as you can see, some of them here, Ukrainia, I guess they have 90% they don't even achieve. So probably that's what makes Putin unhappy. And here's the other study. You also, I'm sure you're all familiar with the Da Vinci trial, which have almost 6,000 patients. 3,000 for primary and 3,000 for secondary, and only 18% get the LDL less than 1.4. The ezetimibe was added only 9%. The PCSK9 inhibitor was added only 1% on those patients. The moderate intensity statin was only given 45%, and the high intensity was given 36%. So as you can see here, really we're not doing good at all here still. And with the combination of maximal tolerated statin or high intensity statin with adding ezetimibe, with the old guideline 1.8 or less, 50%, we achieve that. Achieving 1.4 was only 20%. Now, even after adding PCSK9 inhibitor, of course, we double up the target now to 1.4. So we have about 60% of patients, by adding PCSK9 inhibitors to this combination, we're able to 1.4 or less. If you look at this dementia again in a different way, and you can see for primary prevention patient, because as you said, half of the patient was primary prevention, and as you can see, still about 50% of them not achieving the target, the old target, and probably a quarter of them not achieving the new target. And the very high risk patient, the thing's looking even worse. So less than 20%, 25%, they are achieving the recommended society target. Sweetheart, of course, I'm sure you also know about it. This is a study of Sweden for all acute coronary syndrome. They have 40,000 patients with acute MI and followed by 3.8 years, so a total of 168 patients here. This is a big mega study. And what they found really is 27% of patients, they have LDL to be reduction more than 50%. So out of the group, there is a small percentage of patients, the LDL drop more than 50%. Half of them, they drop less than 50%, and about 10-15% actually, the LDL did not come down or even got worse. And here you can see the relation between the target achieved and the cardiac event. For those who achieve more than 50%, they have much lower cardiovascular event comparing to the one who did not achieve the more than 50% or the one who did not really have much changes. And that apply for all MACE or other cardiovascular events. So it kind of confirmed the old relationship we know before, the relation between the LDL and the future events. Here is a Sweetheart, the one who really achieved the target. This is the LDL to start with, and really very small percentage, 18% received the target. And after the 8 weeks and aggressive, basically, intensive statin therapy, the number just increased a little bit. And about 50% of the patient is still not reaching the target, and probably 50 of them they may need to have PCSK9 inhibitors to be able to get to the target. Of course, here is the simulated study. If you have only the statin, you get, this is the one you're going to, percentage of patients you're going to achieve the target. If you add ezetimibe, you can have, of course, higher. And if you add PCSK9 inhibitor on the top of it, hopefully you will be able about 60% or more to achieve the recommended target. So what is the key message? What do the guidelines recommend? You know this very famous slide here, and the one for very high risk patient and those who have atherosclerosis, either clinical event or CT angio or other cardiovascular events or diabetes for a long time with end organ damage. Those that target is less than 1.4 or 55 millimeter. The high-risk patients who have score between 5 and 10, example diabetic patient with intermediate duration and so on. So we really want to concentrate on this very high-risk patient and high-risk patient. Those are the one we see the most in our clinics as interventionists in particular. And we have to try to get to the target because that is the recommended at this time, and I'm sure going to be in the future, the guidelines will be even lower and lower. So we know that for moderate intensity statin, the LDL can drop about 30%. For high intensity statin, about 50%. So if you add ezetimibe, you got 65%. And if you do PCSK9 inhibitor alone, you get about 60%. But you combine the PCSK9 inhibitors plus statin, you get 75%. If you combine all of the above, you got about 85% reduction of the LDL. And that's where you're going to predict what you're going to need for the patient when you see after acute coronary syndrome. If the LDL is 200, very likely you end up with PCSK9 inhibitor in addition to the maximal statin and ezetimibe. Let's just look at the patient quickly. I don't think this is a case designed for the group we have here. This is a little bit more for probably general internal medicine and so on, but anyway, we're going to go over it anyway. It's a 52-year-old male, hospitalized with acute coronary syndrome, is smoker, hypertension, poor lifestyle, olmesartan 20, LDL 3, HDL 0.9, and triglyceride is 2. So all of those are out of the range. And of course, this acute coronary syndrome fit the criteria of very high risk patient. And so that the classification of very high risk patient, we know all of them, all of us, we know this, is somebody have atherosclerosis or come in with acute coronary syndrome or revascularized, or you have CT angio. Now CT angio is a fashion now, and I think this is the best way to evaluate patients with heart disease. And now more and more we discover a lot of silent atherosclerosis. And I think this is a good idea because if we catch those silent atherosclerosis, probably we're going to have much more aggressive management for the patient. Sometimes the patient do a stress test is negative, patient is happy, the doctor is happy, you must go ahead and enjoy your life, whatever it is, your LDL 120, you are fine. The same patient, if you do CT scan under 50% proximal LAD with the asymptomatic symptoms, stress test negative, this patient will be treated differently. He's going to behave better, and the doctor will behave better because we're going to do more aggressive therapy. So in my opinion, really the CT scan is the way to go. And I think if we're looking for really good patient care, I think the CT angio to go. And as we all know, we are waiting for more high-tech where we have the CT angio with less than 1 millisievert and less than probably 40 cc of dye and so on. And also the cost is very limiting problem. Anyway, so of course we know the list of the things that diabetes is very common here. The diabetes with the end organ damage is very common, and very much, most people, they kind of keep this in their mind, but don't really pay much attention to those diabetic. We have a lot of diabetic group here in the Gulf area, and if you check on protein in the urine, almost all of them, they have some protein here. So almost if we look for end organ damage in diabetic for 20 years, almost always you're going to have it. And this will put them in category of this 1.4 or less. Many of us, we do that for acute coronary syndrome, but not necessarily for those with renal failure or the diabetes in particular. The question is very common question is that should we do lipid profile fasting or non-fasting? Just to get an idea of the feeling. Do you order at fasting lipid profile? If you can raise your hand if you order fasting lipid profile. How about non-fasting lipid profile? Yeah. Of course, I don't think this is not right or wrong answer, but the trend nowadays is really non-fasting. In the last 5 years, I just do everything non-fasting because number one, I think this is what actually the heart, the blood vessel exposed to. And fasting may not give us exactly what the daily routine the patient is. And as you all know also, the fasting doesn't really affect much the LDL or HDL. It significantly affects the triglyceride. But that's my point. If somebody have triglyceride non-fasting 500 and the fasting was 120, well, this patient have problem with managing dyslipidemia. And every time he have meal, he's going to have 500 lipidemia. So I think in my opinion, non-fasting is better option for evaluating our patient. kind of similar when we do blood pressure, let the patient sit and see how he does after 15, 20 minutes, check the blood pressure and see where it is. I don't think that's wrong. I think the best way to do ambulatory blood pressure and see what the patient heart and blood vessel exposed to. Same thing for the, but I think that's not right and wrong answer. But anyway, fasting and non-fasting, 20% milligram can be changed with triglyceride. I think it's more than what I said here. And only 4 milligram can be changed with LDL. And basically, I do all my patients for the last several years as non-fasting. What to do with this patient? Of course, obviously, you're going to do a comprehensive global risk factor. Most of those patients, as you all know, they have hemoglobin is A1C at least. If they are not diabetic, they have 5.8 hemoglobin A1C. They are overweight. They smoke. This a global risk factor modification and high-intensity statin to start with, that the guideline actually said, even though I don't know if you practice, if you start combination therapy from emergency room. How many of you start combination of ezetimibe and statin for the first time patient come to emergency with acute coronary syndrome? Yeah, I think probably half. I do that all the time, actually. It's because it's, it is the time when the patient with acute coronary syndrome, with all the acute inflammation process and the theory of that LDL is the inflammatory things. So if we can bring it down as soon as possible, and then if you want to stop ezetimibe, I think stop it later on if you want to. But I think, in my opinion, you have to be very aggressive from the first hour. I usually, every patient combination actually, either atorvastatin 80 with ezetimibe or rosuvastatin 40 with ezetimibe. And of course, this is not a guideline. The guideline says start with statin first, and then you can add on. And of course, this is a very old slide. All of us know the slide. For secondary prevention, almost everybody, in addition to lifestyle management, have to be on statin at the very beginning. They said here, if the LDL less than 1.4, you can give him some time. I think it's still, if somebody have LDL 1.4 or less and have an event, I think that you have to lower it for those less than 1 according to the guidelines, but that the guidelines here said. So I think this needs to be changed to start statin for everyone who have secondary prevention. And as the rest of the things, you're all familiar with it. Of course, the lifestyle, all of us know about the low-fat diet and a lot of, now the fashion nowadays, which I promote to all my patients, is a plant-based diet. I'm very happy to hear this kind of fancy things for them to plant-based diet. I think it works well, but people cannot take it for a long time. And of course, all of us advise patients, the only drink they're supposed to have is water. No soft drink, no hard drink, no fresh juice, because they think fresh juice is healthy. So educating our patient about this, I tell my patient, the best drink is really the water, which is the drink of wise people. So, and they're happy to hear that. And many of the patients stop taking those 0 calorie and 0 stuff. It's all, I don't think I think it's nonsense. Of course, encourage patients for physical activities and to quit smoking. And of course, this is a kind of simple question for us. Patient, the target is to reach 50%, more than 50%, and the LDL less than 55. And here what the guidelines said. The guideline says all acute coronary syndrome, you start them on statin emergency room before even looking at the lipid profile. And as I said, I add ezetimibe in the beginning. And if the patient did not achieve the target in 4 to 6 weeks, you add ezetimibe. And if they did not achieve the target in 4 to 6 weeks, you add PCSK9 inhibitors. I think this is the way they recommend it. And probably, I think that will change. I know there is a study to give even PCSK9 inhibitor in emergency room because it's very fast acting. As you know, as soon as you get the shot in, the PCSK9 in an hour drop to significantly. Of course, LDL takes several hours or a day or so. But the idea, acute coronary syndrome, where there's so many things going on, everything is hot, you need to lower the LDL as soon as possible, because LDL by itself, I think, is a pro-inflammation. And if you lower that one, you may decrease this kind of hot plaque in there. But that's what the guidelines. The guidelines said statin first, 4 weeks, ezetimibe, 4 weeks, PCSK inhibitors if needed. And those, remember the combination of more than 50% and less than 1.4. So this patient got a 40 statin, of course, you have to add ezetimibe, and as the guideline said, and this is what I saw earlier, what I said earlier, add ezetimibe at 4 to 6 weeks, and then this is what we have the slide earlier, that you have the baseline LDL, and you have to get to your target, and of course you do the manipulation according to the guidelines, what they suggest. And this is the same as I mentioned already earlier, that if you are not able to reach the combination therapy, the LDL more than 50% and the target 1.4, then the PCSK inhibitor need to be added. And of course, all of the patients ask for how long, and I think the answer is probably for life, unless they can come up with some genetic therapy or something. And here is the study on the outcome Odyssey trial. Of course, you know that a few years ago we have Odyssey trial to show that lowering LDL with non-statin still decrease the cardiovascular event. And in this trial, it is a big trial, as you remember, there was 9,000 of alirocumab arm, and all those patients on maximal tolerated statin with LDL above 70. And so 9,000 with alirocumab and 9,000 with doing the aggressive therapy and so on. And here is a curve. And the curve, as you can see, there was a hazard ratio 0.85, so 15% relative risk reduction between alirocumab and high-intensity statin ezetimibe with very strong p-value. So we remember the curve that the LDL really dropped 60% in the top of what been at the baseline with the maximum. So combination of alirocumab and statin and ezetimibe, it decreased the LDL significantly and decreased the outcome. So to summarize the story, of course, acute coronary syndrome by default is a very high-risk patient. And the guidelines said to start maximal tolerated statin and add ezetimibe and add PCSK inhibitors as long as you are not achieving more than 50% of the baseline and 1.4 or less. And so basically that's the bottom line. Thank you so much, and I'll be glad to try to answer any question. Thank you.
Thank you very much, Dr. Umar, for the nice presentation. Overview of dyslipidemia. Dr. Ali, you would like to ask? Please go ahead. And then Dr. Abdullah, mention. Tafadhal.
Thank you. Very nice lecture. I have a few questions. One is regarding patients who have very high triglyceride levels, and obviously you cannot calculate the LDL. How do you manage these patients in terms of medication? The second question I have is, what about the role of lipoprotein A? Obviously, there's a lot of data now regarding lipoprotein A and whether we should, measure it in a lot of these patients, especially with ACS patients. And then my third thing, I don't know if you're familiar with it, the pulse test. So it's a new test devised in the United States, protein unstable lesion signature test to kind of stratify patients who are at high risk for cardiovascular events. And should we look at the pulse test in terms of how do we target or how do we treat patients with statins or PCSK9 inhibitors, those kind of things?
Those are a great question, and actually testing my memory, if I can remember all of them. I think I remember the first one, high triglyceride business. Of course, it is very challenging, and you have to have direct measurement of LDL. And triglyceride, if it's very high, need to be fixed anyway. So probably add omega-3 and add fenofibrate and so on. But you can get the LDL measurement directly, direct measurement of LDL and deal with the LDL. And if the triglyceride is very high, you need to be taking care of it, and that's fine. The second question,
Lipoprotein.
lipoprotein A, you know, when we try to practice more of the guideline-related practice because of a lot of things, one of it financial and one of it worrying about the patient. Yes, of course, we have data that say lipoprotein A, it is a risk factor, but sometimes I found it because when that things happened a few years ago, everybody was excited, I ordered the stuff, actually it creates more questions and problems and concern about the patient than answer. I don't order it at all, actually. And some patients ask for it. I said, I can order it for you, but I don't really know what to do with it. And there's data on it. And personally, I don't order it, actually. It doesn't mean that's right. But sometimes it creates more question answer. And the third one, the pulse, I have also was a little bit of excitement. I have few patients on it, and also this create more concern and worry, and we have no really good data on that. I have several patients who order it. Of course, they have to send out the test for USA, and you get the test, and you have all those colorful graphs and what to do with it and so on. I don't think it's appropriate. It's not. I'm not saying appropriate. It's not the guideline. It's not the guideline. I found it the best effective way for the patient to listen to you is do CT angio and show them the blockages and show them if you don't do anything about the blockages, you're going to be in trouble. And I mentioned that before also to different talk. I show the patient the blockages and I tell them this is your problem, not my problem. I can give you the guidance how to fix it. But if you don't listen, that's you. You're going to be in trouble. The data show if you don't do anything about those blockages, you're going to be in trouble sooner and later. And I found it extremely effective, extremely effective. They quit smoking, they behave, they lose weight, they take the medication, and so on. Because visual things to them that something wrong with their heart scare them. And I usually see my patient every 3 months to 6 months, it depends. And every time, you know, the human curve, they listen to you excited, the whole family start to eat salad all day long. And after 1 month, 2 months, they kind of fed up with it and so on. So it'll be that time for the second visit, another second lecture. I find it very effective. Thank you. That was a great question.
Yeah. Dr. Ali, if you have a very high triglyceride and you cannot measure LDL, you know, they use a Fredwell formula, which is inaccurate when you have high triglyceride. Then you go with non-HDL as the second option. And the third option is to measure if you have in your lab, is it lipoprotein B? So these are the two. The lipoprotein little a, there is a literature on it, and PSSK, in fact, effective in reducing 25%. And it's indicated, now it's an emerging risk factor, but it's indicated when you have a vascular event, despite your low LDL, then you think about it. And that's
unexplained atherosclerosis,
yeah.
And you have the little lipoprotein A, probably that may try to work on that one.
Dr. Abdullah, تفضل.
Yeah, I just want to say that triglycerides were only concerned above 500 because of pancreatitis. Otherwise, you deal with it with the statin. The ezetimibe will do most of the work for you, at least 35% reduction of that. Should be our first line. But I'm really concerned about very high-risk patient, the one we deal with. Here is the interventionalist. And our registry shows only a third of them at control. That's at their best with us. So the idea of guidelines sequential, I think, should be changed as well. We should not just target and monitor. We should target and fire. We give out all our weapons at the first time. I use the combination statin with ezetimibe, my day one. And if I think the patient is far away, I use the three together. I mean, that's what I've been doing.
Yeah, the fight's very strong. That's the reason Putin went to Ukraine, because they have only 10%. So they didn't listen, so he tried to give them a lesson.
تفضل دكتور. You will take more questions.
Thank you very much for the nice comprehensive lecture. When we're talking about atherosclerosis, matrix metalloproteinase is an important mechanism in initiating the atherosclerosis, and it works through oxidized LDL or glycated LDL. We concentrate only on reducing LDL. We are not thinking of
Absolutely,
oxidized. That's
doctor.
why we are not achieving by reducing it more. Okay, by reducing all LDL, we reduce oxidized or glycated in diabetics, but we are not tackling the right thing, maybe. In addition to the LDL lowering, we should.
You are absolutely right, is to have a global, actually, global management of the all risk factor, and one of them, the inflammation. We know we have good data on colchicine as anti-inflammation for the long term. The problem with the colchicine is too inexpensive, doesn't have much like media coverage, but yes, anti-inflammation, I think anti-statin or anti-lipid and anti-inflammation, I think should go hand by hand. And probably down the line, we're going to find something else also. And unfortunately, the patient will be taking 10 tablets a day. But yeah, I agree with you. Is not only one problem. I mean, the talk today is only about LDL, but it's not really talk about decreasing atherosclerosis, because it's a very wide things. We can spend a whole day talking about so many different things. But I agree with you. Is LDL is only one problem.
Last question, Dr. Ahmed, تفضل.
Yeah, there is a lot of data now about the systemic nature of atherosclerosis and using of intracoronary imaging for non-culprit arteries. It is now clear and evidenced by OCT and IVUS the vulnerability of non-culprit arteries in the setting of acute Crohn's syndrome. So PCSK9 is very important for stabilizing all these vulnerable plaques. I asked about there is a lot of data also recently to start PCSK9 as early as possible from even the first day of admission after acute Crohn's syndrome. What do you think in patient who is admitted with acute Crohn's syndrome and naive for any anti-lipids, when you start the timing of PCSK9 exactly?
Quickly, I agree with you that non-corporate lesion is 40% of second event later on, and you have to be aggressive. Well, the guidelines said really go for, right now I just start with statin, maximal dose statin, anizitamab from first day, even from emergency room when the patient come in, take aspirin, clopidogrel or ticagrelol, and I give him also a high dose of 80 milligram atorvastatin, anizitamab 10, from emergency room from very first hour. And if the lipid profile come in next day, I mean, it's very high. I know it's going to be only get 60%. So if the LDL came back 200, very likely the regimen not going to fix it. And probably that patient will receive the shot of the PCSK9 inhibitors at the very first day, I guess the second day after we have the result. Because we know that how much we're going to predict. And if you're looking for 55 or less and start with 200, you're not going to get there unless you add the third therapy from very early. But we're looking for, I think the guideline need to be updated a bit more.
Dr. Umar Halaq, thank you very much for your nice presentation and sharing the answer with the audience. I would like to thank you very much again. And now